Okay. Hey everybody, Dr. Arafat from Vet Triage here. It is November 23rd, Saturday, 11:09 a.m. Pacific time. We are going through this 2015 issue of Veterinary Surgery, and we are looking at this paper here, initial experience with recombinant human bone morphogenic protein 2 delivered in a compressive resistant matrix for mandibular reconstruction in 5 dogs. Forewarning, this is a robust paper, so it's going to be a bit long, but it's a lot of useful information coming out of Cummings School of Veterinary Medicine in Tufts University. The objective is to document cumulative initial experience and follow up with the use of BMP2 and the compressive resistant matrix, CRM, for reconstruction of mandibular defects that are at least 5 centimeters large in dogs. Retrospective study, 5 dogs from 1999 to 2011. The results show that mandibular reconstruction was successfully performed in all dogs who had gaps of 5 to 9 centimeters. Surgical reconstruction restored cosmetic appearance and function. They found bone formation based on palpation 2 weeks postoperatively, radiographs by 16 weeks, minor complications in all dogs. These include firm swelling and gingival dehiscence with plate exposure, and then exuberant cystic bone formation. 2 dogs had minor long-term complications of plate exposure and non-vital canine tooth. Long-term follow-up in the hospital, 5.3 years. Over the phone, 6.3 years. Okay, introduction. Mandibulectomy is commonly used to treat dogs with benign or malignant mandibular tumors and severe trauma. When mandibulectomy results in a large bone defect, malocclusion, difficulty in eating, drinking, prehension, and pain of the other TMJ can be consequences. Increased cost of this procedure, the difficulty to routinely bridge large defects, and the perception that reconstruction is not necessary. Reconstructive techniques have been devised, including rigid internal fixation in combination with a variety of graft, including cancellous autograft or allograft. Cortical autograft with either vascular or avascular or allograft have been used less frequently. Autogenous cancellous bone grafts have been considered the best method in people. The use of cancellous allografts, cortical autografts, or allografts, extraction osteogenesis, and graft substitutes have been developed to augment or substitute for limited availability of autogenous cancellous bone. Vascular clavicular or fibular cortical bone autografts are currently the methods of choice for managing mandibular defects in people. Vascularized cortical autografts, although very successful, require specialized instrument and skills. Free cortical autografts are limited to small mandibular defects. Bone allograft currently available products include cancellous chips and or demineralized bone matrix powder, cancellous blocks, cortical end segments, or struts. Allograft bone can induce osteoinduction, osteoconduction, or both. Matrix bone graft substitutes include ceramics such as hydroxyapatite, tricalcium phosphate, calcium phosphate cement, synthetic polymers, and ceramic or polymer or naturally occurring fiber composites that stimulate osteoconduction also are commercially available. Matrix bone graft substitutes have been used for mechanical support and as delivery vehicles for osteoinductive factors, particularly bone morphogenic proteins or BMPs. The demineralized bone matrix containing residual amounts of endogenous differentiation factors resident in bone was one of the first osteoinductive/osteoconductive bone graft substitutes used. BMPs are potent differentiation factors capable of initiating the entire sequence of bone formation in ectopic non-bony sites. The combination of BMP2 delivered in an absorbable collagen sponge carrier has been approved by regulatory agencies as an alternative to bone grafting for the treatment of open tibia fractures, augmentation of interbody vertebral fusion, and alveolar ridge augmentation in humans. The combination of BMP2 delivered in various carriers has been used off-label alternatively in people. In animal models, this combination has been used to accelerate osteotomy healing, to bridge segmental bone defects, and to generate spinal fusion. And these are reported to be equivalent to or superior to autogenous cancellous bone grafting. Furthermore, BMP2 results in rapid bone induction. There is a single product approved for augmentation of fracture healing in the European Union, and it is delivered in an absorbable collagen sponge. Reconstruction of mandibular defects in dogs using BMP2 with a compression-resistant matrix has been described clinically. Compression-resistant matrix is a composite collagen sponge containing hydroxyapatite and tricalcium phosphate granules. The inclusion of these granules confers that required resistance to soft tissue compression necessary to allow bone formation within the defect without interference from encroaching soft tissues. In addition, there's been some anecdotal use of BMP2 for reconstruction of partial mandibulectomies as long as there's an intact bony bridge. So that's the introduction, folks. Materials and methods. Surgical planning. Radiographs of the skull include left and right lateral oblique, dental radiographs, and CT scan. They use a minimum of 3 to 4 screws in the intact mandible on either side of the gap. Surgical technique. In dogs with an intact mandibular canine tooth present, immediately rostral to the defect or planned resection, a root canal of this tooth was performed. A wire-reinforced endotracheal tube was placed through a pharyngostomy incision. And if you've been watching our live streams the past couple of days, a lot of these studies have been leading up to this study. So a lot of this information is in older live streams if you want to take a look over the past few days. A ventrolateral approach to the affected mandible is performed to expose the gap planned for mandibular resection. An alveolar plate called a mini plate was applied to reestablish occlusion across the gap. A larger locking stabilization plate was then applied to the aboral surface, which is the ventrolateral margin of the mandible, again bridging the defect. The final solution concentration of 0.8 to 1 mg per ml of BMP2, the appropriate volume of BMP2 equivalent to 50 to 60% of the volume of the compression-resistant matrix sponge was uniformly distributed over the entire surface of the sponge to achieve a final target concentration of 0.5 mg per ml BMP2 with that sponge carrier volume. All right, now the results. Dogs 2 and 4 were immediate reconstructions. Dog 5 was reconstructed 4 weeks after resection of a histologic tumor that the margins were cleared before that surgery was performed. Dog 1 was reconstructed 8 months after a hemimandibulectomy and had severe mandibular drift and angular and rotational deformities. And dog 3 reconstructed after debridement and treatment of gunshot wound. They used a 2.0 millimeter standard mini plate as an alveolar plate, and then a 2.4 millimeter locking reconstruction plate as a stabilization plate. And we'll go over what those things mean during the conclusion. New bone formation was seen on radiographs in approximately 8 weeks, but from 8 to 16 weeks, the granular opacity of these granules began to coalesce and disappear. Bone formation was more evident because of a trabecular rather than a granular pattern of radiodense material, bridging the original defect. And here are pictures. Ooh, look at that. So A shows you the positioning of the dog, and then here in C, you've got the bone plate, and you see all the little granules in the middle of the picture of the bone plate, all those granules. And you see the x-rays in D and E. D looks like preoperatively with a root canal in that lower canine, and then E has the bone plates. Ugh. All right, let's see. No evidence of original tumor at the time of euthanasia, and it was euthanized for unrelated reasons, with long-term follow-up at 6.5 and 12.5 years, respectively. Vascularization and viability of the graft were assessed using radiophosphate 99-MTC-MDP scintigraphy. That's nuclear scintigraphy. They inject a radioactive isotope into the dog and then measured, I think, on x-rays, but I'm not really sure. And the idea is that radioisotope will accumulate in certain parts of the body. Usually those parts of the body have increased vascularity. And consistent with ongoing bone remodeling and associated with the defect bridging. All dogs had swelling of the mandible in the region of the graft that peaked at 6 to 10 days, which is expected from angiogenic pharmaceutical effects of BMP2. Minor complications with 100%. Exposure of the crown of the canine tooth fractured. And another one had that, and then they had that tooth extracted. Dehiscence of the gingival suture line with exposure of the alveolar plate occurred. Mini plate exposure as well occurred. Both plates removed at 20 months after exposure of the plates. Cystic or exuberant bone formation evident, no treatment necessary, and the bone remodeled over the next 4 months. And here is a picture in A. Let's see here, this one. So in A, there, you can see the swelling, the person's hands under the dog's jaw showing the swelling, and then B shows the nice occlusion. And then for this section, you can see more, you can see in A, the plate is outside the gingiva, which is not normal. It's not what you want. So they remove the plate, and then in B, you see the closure. And then in C, you've got the preoperative with 2 plates, and then D shows postoperative with the 1 plate after it's removed. Okay. Subjectively, increased dental calculus was accumulated on the dental arcade opposite the full mandible reconstruction in all the dogs. Due to asymmetric mastication, no dogs reported to have periodontal disease long-term. Mean hospital follow-up in the hospital, 5.3 years. Over the phone was 6.3 years. And now finally the discussion. So here's another picture here, right there. This makes you guys dizzy, huh? Boy, this is really ghetto. A shows arrows pointing to a lesion in the dog's bottom jaw from a sequestrum. B is supposed to show with the arrows there exuberant bone formation. C, they removed a bunch of the exuberant tissue and the bone spur that was present, and then closed the dog up. And then you can see the x-rays there. The arrow head shows bone formation in the soft tissue, and the actual arrow itself is where the bone spicule was. And then this is just showing biopsy of the area in these dogs, in case you're interested in that. The biopsy shows large, abundant, dense, mature, fibrous tissue surrounded by arcing spicules of new bone. And the spicules of new bone are lined by hypertrophied osteoblasts. All right, discussion. Postoperative swelling adjacent to the surgical site and the pharyngostomy site resolved within 1 to 2 weeks. New bone formation was present within the defects as early as 2 weeks based on palpation, and radiographs show bridging by 16 weeks. Most of the carrier molecule was resorbed by 16 weeks. Take a little break here. The skeletal hallmark of the BMPs is their ability to enhance osteoinduction and bring about de novo bone formation. As chemotactic agents, BMPs influence migration of progenitor and stem cells to the repair site, followed by stimulation of angiogenesis and stem cell proliferation. As differentiating factors, BMPs induce the maturation of stem cells into chondrocytes, osteoblasts, osteocytes. The effects are enhanced when BMPs are combined with a carrier matrix. The use of BMP for mandibular reconstruction, as reported, is an off-label indication in dogs. BMPs are only approved as an alternative to bone graft for the treatment of option of tibia fractures, interbody vertebral fusion, and alveolar ridge augmentation in people, but they do use off-label in humans, and one use has been for mandibular reconstruction, successfully reported. BMPs are capable of inducing new bone formation. They are not reliable or effective as a gold standard of autogenous bone grafting. It should be noted in these reported cases, the carrier sponge, and in some instances mixed with Cancell's bone chips, hyaluronic acid, or the bone matrix. Additionally, it was recognized that the surgical technique must maintain the created space to prevent collapse of the grafted area until calcification of the preosseous matrix can occur. Not only must BMPs be administered in much higher doses than in people, not compared to other species, for osteoinductive activity, but the carrier is also important, its physical makeup and the retention profile, all of which contribute to the inconsistent bone formation in previous reports. One problem with this paper is they didn't report what the postoperative care for these dogs were. Like, I don't know if they were on antibiotics or either injectable in the hospital. I presume they were, and did they go home with antibiotics, things like that. With mandibulectomy alone, the possible complications associated with this procedure can result in a lifetime of issues that include a diminished quality of life and jaw pain in about 20% of cases, with possible degeneration of the TMJ. Elastic training, extraction, and crown reduction or vital pulp therapy for traumatically occluded teeth have been used to address these issues. Elastic training is not always successful and requires continued good owner compliance. Furthermore, even in the short term, such mandibular stabilization is reported successful in only 50% of cases, whereas extraction and crown reduction can palliate pain. These techniques do not reestablish normal occlusion and may predispose to TMJ degeneration. Here is a skull of one of the dogs that were euthanized, again, unrelated to the surgery. And you can see the red arrows are pointing to the exposed implants there, but the bone looks healed. Although the reported occurrence of radiation-induced carcinogenesis is quite low, it is higher than that found after complete surgical resection, meaning no possibility of tumor induction. There is conflicting evidence as to whether BMPs can be linked to tumorigenesis or what their role might be in promoting cancer. Based upon a current literature review, there are conflicting studies regarding BMPs in promoting tumorigenesis and metastasis. Human oral squamous cell carcinoma cell lines combined with BMP2 before engraftment in an orthotropic animal model cause tumors to be more locally aggressive with a worse survival. Now, potential issues are going to be discussed regarding the BMP formulation. There is recent evidence that in large cranial defects in dogs, that the lower dose is not as effective in generating bone, whereas 0.4 mg per ml of BMP in a matrix produce the most consistent results. Higher than desired concentrations of BMP can cause exaggerated bone response with cystic bone formation. Additional potential causes of excessive bone formation relate to implant formulation, including waiting insufficient time to allow BMP to bind to the carrier before implantation and less than optimal control of hemostasis. A minimum of 15 minutes after adding the BMP2 solution to the sponge is required. This time has been demonstrated to allow over 90% of the protein to bind to the collagen and ceramic components of the matrix. Premature implantation can cause transient bone resorption when used in metaphyseal bone locations. And you also want to control hemostasis to avoid competing BMP2 release off the carrier by serum proteins, which have a higher affinity for BMPs than the carrier proteins. Poor hemostasis increases the chance of developing significant heterotropic bone resulting from BMP2 bound to serum proteins migrating along fascial planes, create along the surgical approach. Okay, now in regards to postoperative soft tissue swelling. The immediate postoperative soft tissue swelling adjacent to the graft was expected because of increased angiogenesis from BMP2. BMPs upregulate vascular endothelial growth factor, or VEGF. The high protein transdate originating from the large number of leaky blood vessels induced by BMP2 may be the source of BMP2-induced postoperative swelling. Infection is another differential. However, the lack of associated pain and erythema ruled this out. Excessive soft tissue swelling can be associated with increased risk of incisional dehiscence, such as early devitalization of gingiva along the suture line because of the excessive nature of the resection in one of the dogs. Now, in regards to gingival plate exposure, the basic premise of fracture fixation, this is important, of the mandible has been dual fixation with an emphasis in the biomechanics. Fixation of all 5 dogs was placed along tension band alveolar surface to most effectively neutralize the substantial bending forces in the canine mandible. The second ventral stabilization plate was placed to neutralize the shearing and rotational forces. Since bending forces are the primary forces to be neutralized for these large gaps in these large breed dogs, placing an alveolar plate to most effectively neutralize the distracting forces along the alveolar border follows biomechanical principles. Further, substantial torsional loads also exist and are more readily neutralized with the addition of a second plate. Placement of a second plate parallel in the same plane increases the bending and torsional strength of the fixation. The use of a single ventral plate of adequate strength in the dog may decrease the incidence of wound dehiscence or late plate exposure. However, using a single plate has not been documented to be consistently efficacious in fracture repair. The rationale to preferentially placing locking plate fixation is because of the expectation that prolonged healing may occur over large gaps and that standard fixation would not remain stable for that period of time. Standard plates and screws obtain their stability by compressive forces generated between bone and plate. These forces may be easily overcome by large mascatory forces. Locking plate fixation alternative does not rely on these compressive forces for stability. Locking plates are fixed angle stable devices that can provide better long-term stability. Point contact with the bone ensures maintenance of vascularity at the bone plate interface, and reduces the incidence of infection. It is well established that the force distribution relationship between teeth and mandibular alveolar bone stimulates remodeling and maintains this bone height. Dehiscence and/or late plate exposure with the mandibular reconstruction is not unusual in people. Guided bone regeneration mechanically excludes non-osteogenic cell populations from the soft tissue and promotes a more permissive environment for recruitment and proliferation of osteoprogenitor cells. Such techniques are frequently used in people for dental socket preservation and alveolar ridge preservation. It's efficacious in animals for reconstruction of critical size bone defects. A thin, flexible sheet of demineralized cortical bones placed along the gingival surface and around the alveolar bone plate before placing the matrix in BMP2 in one of the dogs in the study. Now, the use of mandibular canine tooth for rostral plate fixation, this is the final section here. The mandibular canine tooth was used as a point of rostral anchorage for plate fixation. Penetration of a tooth root with a screw would result in vascular compromise, death of the tooth, increased infection, and increase of periapical abscess. An osteotomy performed adjacent to the apical portion of the canine tooth would likely result in death of the tooth as well. Before using this tooth as a purchase point for rostral plate fixation, a preemptive pulpectomy was performed. Performing the pulpectomy was an attempt to mitigate the possible complications associated with tooth root penetration while preserving a stable rostral anchor point for the plate. And then finally, despite the potential issues raised with the use of BMPs in people with regard to pain or dysfunction from either ectopic or cystic bone formation or tumorigenesis, no such clinical issues were observed in this study. All right, pretty cool paper, very comprehensive. We'll be back again tomorrow for another one. Thanks to those who watch us on playback, who stay for the whole thing. I know it's a lot of medical terminology. You have to have a basis of medical knowledge before understanding this stuff, but some of these papers are just too robust to explain every single term that's there. So hope that helps. We'll see you again tomorrow. Take care.